Respected panelists and audience, a very good morning. I'm Meghana, Senior Resident, Department of Endocrine Surgery, King George's Medical University, Lucknow. I'll be presenting on port rotation. We had a 52-year-old lady who was diagnosed with gastritis, clinically T3N1M0, ER/PR negative, HER2 positive, Ki67 of 70%. She received dose-dense neoadjuvant chemotherapy, 4 cycles of adriamycin and cyclophosphamide, followed by 4 cycles of paclitaxel, along with 2 cycles of trastuzumab, then underwent right MRM, followed by post-mastectomy radiotherapy. Decision was made to insert chemo port for adjuvant targeted therapy. Chemo port was inserted into left IJV following standard protocol under fluoroscopy guidance. Post-procedure chest X-ray showed the tip to be in SVC. During third cycle of adjuvant trastuzumab, we experienced inability to pierce the port chamber, aspirate blood, and administer chemotherapy. So based on that, we got a chest X-ray done. The picture onto the left of the screen was that of the initial chest X-ray, and onto the right of the screen is that of the chest X-ray done after facing problem in the third cycle. And as seen, the port was flipped. So that prompted us to post her for a reoperation under local anesthesia, and intraoperative we could see a rotated port chamber, the plastic side of the port chamber facing front and the diaphragm facing backwards. It was repositioned, patency checked, fixed to the pectoral fascia with braided sutures, one size larger than the earlier. Totally implantable venous access device play a key role in chemotherapy of breast cancer patients. The advantages of a subcutaneously placed port is that it is invisible, it avoids infection, it avoids social and emotional stigma, and improves quality of life. However, complications remain common in this procedure, and the reported incidence is about 27%. The complications can be divided into early complications and late complications. The early complications occurring within 30 days of insertion, and the common ones are the catheter malposition, extravascular placement, hemothorax, pneumothorax, thoracic duct injury. The late complications occur after 30 days, and the common ones are infection, venous thrombosis, the mechanical complications of the port per se, that includes port chamber rotation or flipping, torsion, catheter twisting, entrapment, kinking, fragmentation, or migration. The mechanical complications limit the port catheter or the chamber use, and the reported incidence of this particular subset of late complication is 4.3%. Amongst which rotation of port chamber or flipping is a very rare complication, and the reported incidence in literature is 0.1 to 0.4%. The term torsion, flipping, or dislodgement regarding port reservoir can be used interchangeably. So what causes port chamber rotation? Use of absorbable sutures for fixation, loose fixation to the pectoral fascia, manual repositioning, thin-built individuals, pediatric population, inadvertent multiple attempts at placing the needle out of the silicone membrane, rectangular design of the port with relatively narrow base, anchoring to the subcutaneous tissue, and excessive ipsilateral arm movements. So there's an entity called as Twiddler's syndrome, that is port inversion is directly attributed to this. So it was first identified and named in 1968 by Bayliss et al. With reference to implantable pacemakers. But it has also been noticed in other implantable devices like chemo ports. So it is unintentional or intentional manipulation of the port beneath the skin, which results in enlargement of the fibrous pocket, and in the longer run results in flipping. So what are the preventive measures that we can take to prevent this, avoid this complication? First is placement of, it has been advised that a port can be placed in subpectoral facial pouch, and creation of a tighter superficial skin pocket for the port placement, use of non-absorbable sutures, and appropriate patient education, as in discouraging frequent touching or manipulation of the port site. The learning points from this case were inability to pierce the diaphragm should make us think about port flipping being a possibility, even though rare. A preliminary chest X-ray will clinch the diagnosis. Port removal is not necessary. Repositioning is sufficient, and it can be prevented by use of non-absorbable larger sutures and good fixation technique. Thank you.